A very common question I get from doctors who are new to the myofunctional orthodontic system, and that is, where's your research? I like this question because now, after 20 years of using the appliances, we have comprehensive research not only on the trainer and the MyoBrace system, but also we can look back at 100 years of orthodontics and see exactly what the research and the success is of conventional orthodontic treatment. So over the last 100 years, from Angle through to Tweed and Frankel and Graeber, there's plenty of evidence that shows that soft tissue dysfunction is driving the malocclusion. And more recently, John Mew has emphasised that posture of the mandible, posture of the tongue is so important. Weston Price showed that malocclusion was very much related to nutrition, and we have to look at that aspect when we're doing treatment. So what have we achieved over the last 100 years? Let's look at some of the research on orthodontics and see what we've come to. Recently I came across this quotation in Graeber's current edition of his textbook. The chapter is entitled Interceptive Guidance of Occlusion with Emphasis on Diagnosis. The quotation is from Tweed, and he says, "We will acquire a better understanding of when and how to intervene in the guidance of the growth process so that nature may better approximate her growth plan for the individual patient." He also says, in other words, knowledge will replace harsh mechanics. See, Tweed is talking about harsh mechanics, meaning brackets and wire, forcing the teeth into an unnatural position. And he says, in the not too distant future, the vast majority of orthodontics will be carried out in the mixed dentition period of growth and development, and prior to the difficult age of adolescence. There are quite a number of articles now illustrating the problem with retention in orthodontic treatment. We now know that after we put the brackets on, we can very efficiently straighten the teeth, but we need to have permanent retainers to get any sort of stability. And more, most lecturers are recommending permanent retention. The problem when the retainers come off, even after many years, we know there is a good possibility that the teeth will relapse. We know this from the Little studies, very famous studies. He's written many articles, and you'll see prior to treatment, some crowding, 4 teeth were taken out, retainers put on, and the lower pictures show 10 and 20 years after the retainers were removed. Interestingly, you see that the relapse is actually greater than the original malocclusion, bringing us to the conclusion that these cases are actually highly unstable. And Little noticed that crowding increased during the 10 and 20 year post-retention period, crowding so much that only 10% of the cases were acceptable. So now we are at the point where we have to tell the patient, so we're using fixed appliances, and this is directly from the website of the Australian Society of Orthodontics, and that is that teeth will have a tendency to change their position after treatment. The long-term faithful wearing retainers should reduce this tendency. Occasionally, as they say on the ASL website, occasionally tooth movements will be severe enough to merit a further course of treatment to ensure a satisfactory result. That means that most orthodontics, as it is practiced with fixed appliances, tends to be unstable. So we're relying on glue and wire to hold the teeth in position. And as Little says, the only way to ensure continued satisfactory alignment after treatment is by the use of fixed or removable retention for life. The other aspect now is that root resorption is becoming a major topic, especially with the continuous force archwise. We now have better ways of researching root resorption, and we're finding that most cases with fixed appliances get root resorption, not just on root shortening, but also on the root face. So Professor Darren Dyler from Sydney University Orthodontic Department says virtually now everyone will get root resorption and minor root damage from fixed appliances. And he says it's up to 100% of cases and can be up to 4 millimeters of root shortening. Now, he also found in his very good research papers that although it may not be clinically practical, compared with continuous forces, intermittent forces might be a safer way to prevent significant root resorption. So now a lot of people are saying that we should not have continuous forces, we should have intermittent forces. Another study out of Japan concludes the same thing, 8 hours on, 8 hours off with the arch wire, so the forces were intermittent. Their conclusion was that 8-hour intermittent force efficiently recruits osteoclasts while causing minimal root resorption. And that's the technique I'll show you today. The bent wire system and MyoBrace systems use intermittent forces, therefore have minimal root damage. We also noted with the bent wire system that the teeth, although they're moving quite away, are not becoming loose. So we feel that we're moving the alveolar bone rather than just bodily moving teeth, which is a very good point because it's much safer, we feel, on the teeth. Another aspect of the ASO website is that very much pro, as we are, early treatment. Early treatment may prevent more serious problems from developing and make treatment at a later age shorter and less complicated. Now we know that, and that's why we're always trying to get in early and treat myofunctional habits. Early treatment may also achieve results that are not possible once the face and jaws have stopped growing. Absolutely agree, and that's our MRC philosophy, in keeping with the same philosophy of the Australian Society of Orthodontics. So our goal is, over the last 22 years, is to correct myofunctional habits as soon as we see them. And that's based on the research and based on what everybody believes is the best thing to do. Here, Herman Ramirez will explain a bit more about the research into the trainer.
We want to be really weird, and we don't want to accept something new. Immediately we say, where is the scientific evidence? I haven't read anything about this. Where are the studies? And we start asking the people for statistics that we don't understand, just to get rid of them. All right? So what happened? 5 years ago now, Dr. Yusuf Mays, I'm going to go quick on this, did a study showing that we were talking that the trainer produced a sagittal effect. All right? So we need to produce that. So he did cephalometric measurements. You can read this paper. You can download this paper from the web. So I'm not going to spend too much time on this. But basically, what we wanted to see is the effect on the SNA angle and the SNB angle to see if it was really a change in the posture of the mandible. And he found that there is a significant increase where you see, I am going to teach you statistics in 1 second. When you see asterisk, it means that there is a significant difference. So here we have 3, it means that there is a real significant difference in the measures before and after treatment. All right? Now you are a statistician, all of you. All right? So the SMB angle just increased significantly, which means that the mandible was reduced, so was positioned forward, all right? This angle increased. And obviously, because this effect, the A and B angle is going to be affected as well. But what was interesting for me, from this study, I started saying why this angle is changing. The selanation, which is the cranial base, with the gonion-nation was reduced. What was showing me that the mandible was rotating. And I started saying, what? This was very interesting in 2004 for me. All right? So keep that in mind. And then we were saying that the trainer produced a transverse effect, stimulating transverse development. And we did another study that I was involved in with patients from Brazil, Australia, and Lithuania, from different regions from the world, and we collected 60 cases that were treated with the trainer, and we measured the distance between the teeth, the transverse dimensions, and also the overjet and the overbite. And we found that all the dimensions increased significantly in the patient. So we demonstrated with this study. So what is the modus operandi of the trainer? We can say today that the trainer changed the posture of the mandible, and that was demonstrated in the USUMES study. And is published in one of the most recognized journals in orthodontics, the Angle Orthodontist. So if you want to read the full paper, you can go to the Mayo Research website. If you go to my page, the research page, you will find this paper, and you can download the paper, the full paper, and you can have that. All right? The second point was that it stimulates transverse development. And that was demonstrated in my study in 2007, and it was published in the Journal of Clinical Pediatric Dentistry. So the evidence is published in peer-reviewed journals. Okay? So here, the same, you can download this paper from the web page. When you enter, just check on the left side of the web page, and you have a link there, research, and that brings you to my area of the web page, and that area is going to show you all my publications, and you have these papers. You can download all my publications, even related with the trainer or in other areas that I have been researching. All right? The other point is that it improves the incisor alignment. And we observed that also in the two previous studies. And we did another publication that is also in the Journal of Clinical Pediatric Dentistry, showing the most dramatic situation is the class 2 division 2. And we show it in that paper that we can correct that incisor position with the trainer without any problem. So this paper is also published in the Journal of Clinical Pediatric Dentistry, and you can get that from the web. So at that point, let's say that skeletically and dentally, we have enough evidence to show that the trainer is produced the effects that we claim it produces. And you can get those papers. So please stop saying, where is the scientific evidence? Go there and you have the scientific evidence on the web.
More research on the trainer. This is one of the ones I like best. It's out of Japan, out of the Japanese Journal of Clinical Dentistry, showing the trainer and its use in various age groups. The research was from a group of patients in private practice, in an orthodontic practice, and the original goal was just to do early treatment so it made the cases easier to treat with brackets. But what they found is many of the cases were so good that the parents said, I don't need brackets. So what you see here is the result of the trainer system, and that is consistently you get better arch form, that anterior arch form improves, bites open, dental alignment improves. And that's in keeping with the research that Herman Ramirez did, and this is exactly mimics his study. We're showing the molar changes, premolar and premaxillary changes. Most of the arch width gains are in the anterior region, but overall the arch width widens because the tongue is doing functionally what it should do. So in many cases, very consistent results shows the chef the improvement of craniofacial growth and consistently that improved arch form. And this is not so much because the trainer has a lot of force on the teeth. This is just changing in function. So what we're trying to do is get the big guy, the tongue, and the other guys, the lips, to work for us in improving dental alignment. 500 grams of force is a force that the tongue can exert quite clearly. It's capable of expanding the arches and aligning the teeth.